So looks like Avril's ready to tell us all about what PRRT even is.
Thank you, Michelle. Thank you for your patience, everyone. I'm slowly getting the hang of this technology stuff. So PRRT, I know everyone is, again, different levels of expertise in the group. I'm sure there's some people even here that I can't see who's that have had PRRT. Oops, why is that not working? Oops. Okay. So as you well know from what Michelle said, previously to this year, PRRT was not funded in New Zealand, and so people were travelling across to Australia and funding it themselves. PRRT has been a treatment that's been used internationally for over 20 years. And unfortunately, there was never a lot of research done on it because randomized controlled trials are very hard to do on a small patient group. But there was one done, the NETA-1 trial, and it's thanks to this trial that PHRMAC have agreed that it's a treatment that should be funded in New Zealand. So as if you didn't join our PHRMAC session was it last month, you'll know that, or you might know that PHRMAC only consider medications that have research to back up or evidence through research to back up that they should be as backup to, oh my gosh, my words are going all over the place today, to prove that they should be funded and used in New Zealand. So Michelle's already gone through some of this, so I won't go into it. So PRRT in New Zealand became a big thing, probably most importantly to me, in July last year, when they set up a rapid response group to finally work towards getting PRRT in New Zealand. And actually we did do our first treatment in New Zealand in September last year, using interim funding from the Ministry of Health, because we had patients partway through treatment that had been accessing treatment through the high cost treatment pool. And because they were partway through treatment, it was considered really important that they should be able to finish their treatment, but obviously COVID put a stop to that. And this really helped get funding in New Zealand for PRRT. And so that business case was submitted to the Ministry of Health last year. And then Michelle's showing me up once again, and that her slides are more up to date than mine, because that should say July 2021, PRRT is now funded in New Zealand and is available to everyone who is eligible for the treatment with a neuroendocrine tumor. So what is PRRT? How does it work? And this is a very cool picture that I found at a conference that I went to, and it basically shows you how the PRRT is given through a vein, and it moves around the body and the blood, and then it's got medications that attach to the outside of those neuroendocrine cells, and then the radiation molecule gets absorbed into the cells and basically destroys the cells. So it's a very targeted radiation treatment that attacks the neuroendocrine cells in the body, which is what we want, because we know that the neuroendocrine cells are growing disproportionately to what they should be as a cancer. So there's lots of different types of PRRT, and the one in the middle is the one that's available in New Zealand. So you can see over time they've tried lots of different variations to the treatment, but there is only one funded in New Zealand, and that is the lutate, and that is because of that NETA-1 trial. They're different because of the types, the rays that radiation extends into the cells or into the area, and so the lutate has a radiation penetration that's wider than the in-tate type, but narrower than the Y-tate. It's actually quite confined just to the area where it gets absorbed into the cells. It's very advanced and very, very clever. So that's the one that we use. So PRRT isn't available or isn't suitable for every person with a neuroendocrine tumor. In order to be considered a candidate for PRRT, people need to have had a GAT8 scan, and that GAT8 scan needs to show where your tumors are growing, and they need to be shown at a certain avidity or level. If they don't light up brightly on those scans, it probably means that you will not be a candidate for PRRT. Another thing that needs to happen is that if you've got a neuroendocrine tumor with a higher Ki67, you'll also need to do a different type of PET scan, an FDG PET scan, because we know that the cancer is growing slightly faster, that you need to have the normal PET scan, which is the FDG scan, meeting or having, when that lights up, it needs to match where the GAT8 scan lights up, because we know that the FDG scan, that faster growing cancer area, is the area that we need to target. And if that doesn't fall within the same regions as the PET scan, the GAT8 PET scan, then the disease isn't going to get targeted by the PRRT. I hope that makes sense. And so it's really important that the right scans are done prior to even thinking about having PRRT. And those are essential criteria for getting to a point of having PRRT. And as it says there, again, the multidisciplinary team are crucial for deciding. So there are different reasons that people wouldn't be considered for PRRT, if it's going to cause more harm than good, or if you've got an area of tumor that might actually cause damage or increase pain or inflammation in a certain area. If it causes inflammation in a certain area by having PRRT, you might not be the best candidate for having PRRT. I don't know that I made that make sense. Sorry, everybody. And obviously, PRRT isn't curative. Yes, it targets the neuroendocrine cells, and the radiation gets absorbed into those areas, but it's actually more given to help reduce symptoms from the cells causing hormones, or to reduce the amount of tumor in the body. It's not there to remove tumors completely. This is a slide from a patient who I saw at a conference in Australia a few years ago, and it really hit home for me. It was a very technical conference where there were lots of radiation specialists talking about the different levels of radiation given and different circumstances, and this slide was one that I could identify with, because this is kind of that watch and wait scenario. And this chap decided he wanted PRRT for his neuroendocrine tumor, and he went to a hospital and he had a PET scan, and you can see in the first PET scan he had 9 tumors, and then the following year he had another PET scan and he had 16 plus tumors, but he was still told that actually he didn't quite have enough disease to warrant PRRT. And over subsequent times, he had further PET scans, and then finally, 25 plus tumors, he was told, yep, now's a good time to do the PRRT. And that was purely because they didn't want to give PRRT and have it destroy some healthy cells and cause damage to his bone marrow potentially. They wanted it to have the maximum effect on his tumors. I believe nowadays they do tend to treat a little bit earlier, but that might be a question for Dr. Lawrence as to when exactly that is. So to get referred for PRRT in New Zealand, you need a referral from your doctor, and your case needs to be discussed at the National Net MDM, and that's the email for the Net MDM for your doctors to refer to. You cannot refer yourself, unfortunately, and then following that referral, if the Net MDM recommend that you are a candidate for PRRT, they will most likely first request some scans and get those GAT8 scans, plus or minus the FDG PET scan. And then it'll probably get discussed again at that National MDM. And then if at that point they say, yes, you'd be a great candidate for PRRT, your doctor would then get emailed a referral form for PRRT to be referred to the PRRT team at Auckland. And then obviously people are triaged as to most urgent to get treated. So the treatment process for PRRT, people have an initial assessment with a doctor, and this is all still under review. So you have to remember that the service has been an interim service and is now slowly being developed into a full-scale service. And so we're still streamlining things at the hospital to make it the best service possible for patients. But at the moment, patients get assessed by 2 doctors. They get assessed by the nuclear medicine doctor and told, yes, your case is a definite, you're definitely suitable for PRRT. These are the things that you need to worry about having PRRT in your situation. And these are the side effects from PRRT, and they'll go through all of those with you. And you'll also then get assessed by a medical oncologist or an endocrinologist, and they will be assessing what hormones your current situation or your current disease has, and through having treatment, what the effect on your hormones is likely to be. So everyone's hormones can get influenced by having PRRT, and we want that to have as little an impact on you as possible. And so having an assessment beforehand is really important. Then the treatment process, you have a treatment over, I'll call it a 3-day treatment, even though you only have treatment on 1 day. So the day before treatment, you would see the doctors and get consented and then admitted to a ward. Unfortunately, the ward is the only place at Auckland Hospital that the treatment can be done, because that's where the lead line rooms are. So people have to get admitted even though it's only a day procedure. It's a little bit of a political drama. Different side effects that people get told about. You can be really, really tired after treatment, and that can go on for a number of weeks. Like a normal radiation treatment, you can get very tired. One of the things that you need to have alongside, besides having the lutate, you need to have an amino acid infusion, which is given over 4 hours, and that amino acid infusion can cause a little bit of nausea. And so we give antiemetics or anti-sickness medication. And unfortunately, with every medication, they have side effects, and sometimes that can cause constipation. Sometimes we call it flare-up at the tumour site. So with the breakdown of the tumours in different areas, sometimes that can cause pain. So the area becomes slightly inflamed, and it can actually cause a pain episode. There have been some reports of people reporting changes in mood and depression, and some people even have reported hair loss or thinning. It's not very common. Some of the more serious but rare side effects can include bone marrow suppression or MDS, and that's where where our blood cells are made in our bones, in the bone marrow, and that can get affected by the radiation treatment. So it's something that you would have your blood tests monitored regularly through and between cycles of PRRT. So in day 2 of the treatment, you come to the ward and you get hooked up to a drip, and you have your anti-sickness medications first, and then you have your amino acids, and probably half an hour to an hour into your amino acids, the nuclear medicine team come along and they give the lutate over 20 to 30 minutes, and then the rest of the time you have finishing your amino acids before you can go home. And then afterwards, there's a day 3. Part of that is knowing when to carry on. You need to have your pre-medications before the treatment, but then we also give you a couple of medications to take at home to just try help reduce any flare-ups at the tumour site and any nausea from the treatment. You'll also be told about risks of radiation exposure to other people. So the radiation, the lutate is in your body probably for about 48 to 72 hours, but it's in the first 24 to 48 hours that it's at its highest. And so we give you these radiation safety guidelines about coming into contact with other people. Most people are fine actually to return to work within 48 hours. But if you're going near pregnant people or people with young children, then we advise staying away for a few more days, 3 days, I think it is. And then day 3, so the 3rd day of treatment, while you're not actually getting treated, is coming back to the nuclear medicine department and having a scan. So you have a scan to see where exactly that lutate has gone in the body. And that we want, obviously, that lutate to go to the same areas which have lit up with a GAT8 scan prior to treatment. Yes, and so then you can look at those scans with your doctor. And this is just a picture that a patient shared with me of her scans. And you can see in the very bottom, that's a picture of the liver, and everywhere where that lutate was absorbed after the first treatment, then the second treatment, and the third treatment. So you can see over time how it slowly shrank. And so we kind of get an overall picture that she's responding to the treatment. There's lots of information about PRRT out on the web, and we've developed through Unicorn. We've got our own little booklet which you can download off our website. If you've got any questions now, I'll happily try and answer them. To find this.
That's awesome. Thank you, Avril. And people hit Avril up with any questions about PRRT. And the other thing I was just going to do a really big shout out to Avril, who's done 2 amazing presentations for us. So little applause on behalf of everyone, Avril. And also I want to thank your family, because you've got 2 young children who are floating around your house. You've got
they're outside at the moment, Michelle.
Very supportive husband who is making sure that you've got this time to devote to all of us today. So huge thanks on behalf of everyone, because I know how much we all appreciate. Yeah, a couple of new messages. Yeah, some more thanks.